Hello everyone. Good day. Hope you are all doing well. So you're welcome back to our class discussion. I think I'm so excited to be. You can feel it from my voice, right? So I just hope to keep the energy going. I'm just so happy today. So let's get started right away and continue with our discussion on public health pharmacology course. Okay, so for those that are joining us today, maybe this is the first time you're getting to see this video on any platform. All right, my name is Jane Nnenna Ezikeanyi. I am a master student of the National Open University of Nigeria. Okay, public health. So that's why we are making use of the public health guidelines because I'm a student, I'm learning. So this whole discussion is just a foster learning. So just a group discussion, just like the name, all right? So today we're going to be discussing on drug history and evidence-based medicine, all right? So let's just get started immediately to know everything that we get to actually know on this particular topic. Okay? So drug history, what I think from the namesake, it actually explains itself. So a medication history taking is a detailed, accurate, and complete account of all prescribed and non-prescribed medications that a patient has taken or is currently taking prior to current admission or medical care. So this just like a physician or a doctor getting to know the details of every medication or every treatment that a patient is receiving prior to current treatment or admission in a hospital. So this helps you to actually have a whole knowledge of everything about the patient before admitting or before prescribing another drugs, all right? So it provides valuable insight into patients' allergic tendencies, adherence to pharmacological and non-pharmacological treatments, and self-medication with complementary and alternative medicines. So this it just helps you to know everything about what the patient has been taking, has he or she been taking herbal drugs? We discussed herbal drugs in the previous class. Okay, so if you have not gotten the video, I'm going to be linking it in the comment section so you get to listen on or we discuss or what we discussed on phytomedicines. All right. So taking drug history of a patient will just help a physician to know where to start. Okay, to know if the patient had allergic reactions before or which drug has he or she be taking, both whether it's self-medication or prescribed drugs. Okay, so what is the importance of accurate drug history? What's the importance of knowing the history of like what a patient has been taking before, right? Number one, it helps to prevent prescription errors and consequent risks to patients. It's also useful in detecting drug-related pathology or changes in clinical signs that may be the result of drug therapy. Okay, it should encompass all current and recently prescribed drugs, previous adverse drug reactions, including herbal or alternative medicines, and then adherence to therapy for better care plan. So this is just the key importance of why this drug history need to be taken, okay, to prevent prescription errors and then risk that's maybe caused by drug to drug interactions and a whole lot. Okay, so this drug history, there are different sources that you can get this drug history. Number one, you can get it from the patient. Okay, so the patient can if the patient can actually give accurate details of every medications he or she taking, so you can get the drug history from the patient. You can also get it from the family or the caregiver. You can get it from the medication vials or the bubble bags packs. All right. So this medication vial is just like that, all those bottles that's being used to put drugs. Okay. So we also have medication list, the community pharmacy, or the medication profile from other facility. So these are the different sources on how you can get a drug history. Okay, so we have some challenges of getting drug history from some clients. A lot of time you get some patients that maybe experience one. There's some factors also. There's some things that can actually hinder a physician from getting an accurate drug history. Number one is the belief that a physician has all the information. because most patients or most people that are sick believe that a doctor has every details or every information about them. But this may not be actually true because there are some things that is only the person taking the medication actually know, or maybe some over-the-counter drugs that the patient has taken before that he or she is the only person that can provide the details. Okay. So we also have unfamiliar with medications and names. Some patients or some clients are unfamiliar with the names of medications and then the details. Also difficulty recalling. Yeah, a lot of people cannot remember the drugs that have been taken. Also medicated clients, so like some people that are sedated or confused. Okay, just like some aged people that cannot really know what we are even talking about, or people that are under coma or are not in the current state. Okay, correct state to mention the drugs. Also, disease that affect mental status can also affect a client to provide the drug history. Also have language barrier. Yeah, is a great factor. Then we also have hearing impairments, elderly clients, caregiver, medication vials or list unavailable. So these are some of the challenges of getting drug history from some clients. Okay, so let's talk on steps you can use in taking drug history. Okay, so a lot of time, when a patient come into a clinic, the physician has to use different strategies or different means to get this drug history because some people tend to maybe shy away from a lot of drugs, or they will not give you a detailed explanation on every drug they are using. The first step you have to take is you have to interview the clients. Okay, you have to be friendly and ask questions like which community pharmacy do you use, any allergies to medication. So this is just like making the environment very comfortable for the person to talk to you when you want to take the drug history. Because when someone is comfortable with you, obviously the person can tell you anything. Okay, so you have to make the environment comfortable and you can then ask the necessary question that you need. They also have client education. You encourage ownership, like educate the client to bring medications from home at each appointment, especially for those that have difficulty in recalling, or maybe elderly clients that may not be conversant with the names of medications. So you can encourage them, educate them on how they can actually keep up with the names of the drugs, like bringing the drugs or the medication itself to the for clinic appointments. So a very good way of taking history. Okay. We also have reconciliation and documentation. So once an accurate medication history has been obtained, this information should be documented in the patient's medical notes so that subsequently this can be used either by the current doctor or even um, the doctors that these patients will meet in the future. So there should be a proper documentation of this drug. Okay. So also have wrapping up and end of interview. So by the end of the interview, you have to thank the patient for the time and information, ask them if they have any other questions, and also remind them that there will be a time to discuss any changes to medication and provide updated list prior to discharge. Okay, so um this is started as an interview, so there will be a wrap-up time where you get to thank the person, especially when you've already obtained every detail that you want from these patients. Okay, so note that patients are encouraged to bring their medication into hospital to aid medication reconciliation, prevent misdoses, and also reduce undue costs. So these are the different ways you can actually take drug history. It's a very simple practice or activity um, in pharmacology line, okay? But a lot of time these are not really taken serious. But it's something that if one taking serious, you study the list of the importance of taking drug history, right? So there are a lot of benefits attached to it. It helps to prevent prevention errors, helps you to know if this patient is allergic to this drug. Okay. It also helps you to know the kind of drug that the patient is really, really conversant with, or that is really helpful for the patient over time. So this is about the drug history. So we are going to move on to evidence-based medicine. Like I say, from the our general topic, we're discussing on drug history and evidence-based medicine. Okay, so we're going to be going deeper into what evidence-based medicine is all about and everything we get to know about it. Okay. And before that, you remember our rule. Our rule is that number one, for you to keep getting um notification whenever I post content like this, you have to subscribe to the channel. You also have to like this video and also click on the notification so that you get to know whenever I post content like this, especially for those that really need it, maybe for exams or for other, maybe for knowledge sake. All right. So at any point you could not at any point you have a question, you can just drop it in the comment section below. Okay, so let's discuss on evidence-based medicine. What is evidence-based medicine? In short form, EBM is a systematic approach to clinical problem solving, which allows integration of the best available research evidence, number one, with clinical expertise, and then patient values, the third. So note these underlying points because they are the key components of evidence-based medicine. Number one, best available research evidence. Number two, clinical expertise. Then number three, patient values. Okay. So it's just like integrating all these into um clinical scenario. Okay, so it's the conscious, explicit, and judicious use of current-based evidence in making decisions about the care of individual patients. So the term evidence-based medicine has two main um, tributaries. The first is the insistence on the explicit evaluation of evidence of effectiveness when issuing clinical practice guidelines and other population level policies. Then the second is the introduction of epidemiological methods into medical education and individual patient level decision making. So this is just going to explain the major attributes or the key components of this evidence medicine, which is the use of the best available research evidence, and then combination with clinical expertise, and then the patient values in making decisions, clinical decisions. Okay. So EBM was first introduced in the mainstream medical literature in 1992 article as a new approach to teaching the practice of medicine. It allows analysis of complicated material so we can make the best possible clinical decisions for the populations we serve. Therefore, the practice of evidence-based medicine should aim to deliver optimal patient care through integration of current best evidence and patient references, and should also incorporate expertise in performing clinical history and physical examination. Okay, so these are the three components of evidence-based medicine. We have the best available research evidence. We also have clients or population characteristics, states, needs, values, and preferences. So this is talking about the patient's value. And then we also have the resources, including practitioner expertise. So this is talking of the expertise that maybe a physician or a clinician has. Okay, so these three can integrate into come together to make a decision. All right. So that's the evidence-based medicine is talking about. Then other factors that can affect, we have our organizational and environmental contexts can also come in. Okay, so these are the three components. So let's see the 5 steps of evidence-based medicine model. So these are the 5 steps. We have the step one is formulating answerable clinical questions. We have step two, finding the evidence. Step three, appraising the evidence. Step four, applying the evidence. Then step five, evaluating performance. So these are the key steps you can take before you can actually get a key evidence-based um, decision that you can use. All right. So in step one, formulating answerable clinical questions. This means that before looking for evidence, you need a clear um, focused question about a patient's problem. So one of the most difficult steps in practicing EBM, maybe the translation of a clinical problem into an answerable question. Okay, so it's just like the name, formulating answerable clinical questions. Number one, when a client or a patient comes to you for checkup or diagnosis, you have to for you to use evidence-based model in treating these patients, you have to translate those clinical problems that the patient has complained to you into answerable questions, so you can be able to get the evidence or the key um or the things or the ideas you can use in treating these patients using the evidence-based model. So when we come across a patient with a particular problem, various questions may arise for which we will like answers. So these questions are frequently unstructured, they are complex and may not be clear in our minds. So the practice of EBM should begin with a well-formulated clinical questions, and this means that we should develop the skill to convert information needs into answerable questions. And what are the characteristics of these answerable questions? Is that it should be clear, be directly focused on the problem at hand, and answerable by searching the medical literature. So these are very key characteristics of a good clinical question. So indicating that a physician or a clinician should develop that skill of converting these clinical problems into an answerable questions. Okay, so that's the first step in EBM model, formulating answerable clinical questions. So when you've formulated okay, so let's talk on essential components of a good clinical questions by Sackett et al. So they propose that a good clinical question should have four or sometimes three essential components. So this is proposed by Sackett et al. And they give it a mnemonic, PICO or PU. All right. So in the PICO, the P stands for patients or problem, the I stands for intervention, the C stands for comparison, it all stands for outcomes. So is that's always the short form that can help you to remember the key components of a well-focused clinical question. So let's talk on the patient or the problem. How would you describe a group of patients that is similar to yours, or what are the most important characteristics of the patient? So this may include the primary problem, the disease or coexisting conditions. Sometimes the sex, the age, or the race of the patient might also be relevant to the diagnosis or treatment of a disease. Okay, so the second attributes or the second key components of a well-focused clinical person is the intervention. That's the prognostic factor or exposure. Which main intervention or prognostic factor or exposure are you considering? That is, what do you want to do for the patient? Like, is it to prescribe a drug? Is it to change the lifestyle? Or like that is my lifestyle modification? Is it surgery? Like, what factor may influence the prognosis of the patient? Is it age, existing problems? Okay, so this is talking about the key thing you can do, okay, for the client's problem to be solved, for the patient's problem to be solved. That is intervention. Okay, so number third way is comparison, which is optional. Like I say, it's PICO or PU. So you can use the patient intervention outcomes attribute, or you can use the four of them. Okay, so when it comes to comparison, which is optional, it's talking about what is the main alternative to compare with the intervention. Like intervention we've listed above, that will say that is what can you do to um alleviate or to mitigate the client's problem or the disease. Okay, so in comparison, is what another alternative to compare with the intervention you've gotten in the second um component. Okay, are you trying to decide between two drugs, a drug and no medication, or placebo, or two diagnostic tests? So your clinical question should always need a specific comparison. Okay, and then we also have the final one, the outcome. What can you hope to accomplish, measure, or improve or affect? What are you trying to do for the patient? Relieve or eliminate the symptoms, reduce the number of adverse events, or improve function or test scores. Do you understand? So these are this is just like a guideline in helping you to formulate and answerable clinical questions. Number one, you have to know what the person is suffering from. That is the patient or the problem. Then number two, you have to know, okay, what's the intervention or what does this person actually need? What can I give this person to make the person better? Then number three is comparison. Is there an alternative or can I test two different things? Is there maybe I can place the person on medication, or if there not be medication for the person, then the outcome, what am I hoping for? What's the goal for all these for this treatment? Okay. So if you have access to the PHS 810 material, you can see a very key example of these epical questions. Okay. So you can just get access to it and know more about it. So the second step in the EBM model is finding the evidence. So you've gotten an answerable clinical question in the first step. So the second step is finding the evidence. So once you've formulated your clinical question, the next step is to seek relevant evidence that will help you answer the question. So there are several sources of information that may be of help. Number one, we have the traditional sources of information, such as the textbooks, the journals, which are often the key disadvantage of using this kind of information is that they're often too disorganized or out of date. Okay, so a lot of textbooks you can use, maybe they're written a very long time ago and there's no current information on it. So the second source of information of finding an evidence is asking colleagues or experts in that field. But here, the quality of information you obtain from the source can be variable, because maybe the expert or the professional can be talking based on their own experience or based on what they feel that is the best. Okay, so it's going to be variable, and there's going to be variable answers, and it's not going to be the best from this. So the last but not least, which is the current use in finding evidence, is knowledge search engines. So these are the use of different online tools, um, just like the Google, the Medline interface, like the Ovid, the Cochrane library databases, the Embase, and PubMed. So online a lot of these online sites can help you in finding evidence, can help you in finding the latest articles, latest publications, or the latest research on what that particular thing you are looking for, or that particular problem about your patient. Okay, so the third one is appraising the evidence. So after you've obtained relevant articles on a subject, the next step is to appraise the evidence for its validity and clinical usefulness. So there is a lot of research, or there's a lot of publications or articles available online. So the quality of these is variable. So there is need for you to appraise. There is need for you to vet for the valid or the most useful clinical research out there. So putting unreliable evidence into practice could lead to harm being caused or limited resources being wasted. Okay, so research evidence may be appraised with regard to three main areas. Number one, the validity. Is it valid? But two, the importance. And number three, the applicability. That's the usefulness of that particular evidence to the patient or the patients of interest. So you may ask, is this study trustworthy? And also, does it apply to my patient? Okay, so is it important to what I am looking forward to achieving? Okay, so that's the third one, appraising the evidence. So let's talk about the fourth, which is applying the evidence. So when you check for the validity and the usefulness of the article, so the next one is that you use the best evidence along with your clinical experience and patient preferences to make a decision. So you apply the evidence you've actually gotten along with your clinical experience. Remember, the three key components of an evidence-based medicine is that number one is the research of evidence. Number two is clinical experience, and then the patient's preferences. Okay, so you apply all of them all together. So if evidence supports a certain treatment, but the patient can't afford it or has allergies, you find an alternative backed by research. So the evidence regarding both efficacy and risk should be fully discussed with the patient or parents or both, in order to allow them to make an informed decision. All right. So these are all the things that you have to key in, or the key factors you have to know before applying a particular evidence you found. Then step five, which is the last but not the least, is evaluating this evidence. So after applying the evidence or after treatments or decision making, you reflect on what worked well, or what could be improved. That's evaluation. So formal auditing of performance may be needed to show whether the EBM approach is improving patient care. We need to ask whether we are formulating answerable, um, sorry, whether we're formulating answerable questions, finding good evidence quickly, or effectively appraising the evidence, and integrating clinical expertise and patient value with the evidence in a way that leads to rational, acceptable management strategy. All right. So these are the 5 steps of EBM model. Number one, you have to find the answerable clinical questions. Number two, we have to the second one, you have to finding the evidence through different sources that we've listed. Number three is appraising the evidence. Number four is applying the evidence. Then you have to evaluate what worked and what did not work well. Okay, so let's talk on the 3 categories of medical outcomes. We talked on we mentioned about outcomes, that is what we are actually looking forward to achieving. Okay, so there are 3 major categories of medical outcome. We have the surrogate markers of disease. We also have stage or extent of disease. We also have patient-oriented outcomes. Okay, so if another simpler way of classifying the medical outcome just into 2 major ways, which is disease-oriented and patient-oriented. So let's discuss on the 3 categories. The surrogate markers of disease. Some outcomes like the blood pressure level or cholesterol level are merely surrogate markers of disease. So we measure these surrogate markers because we think they tell us something prognostic about the expected course of a patient disease progress, but they do not directly impact on how a patient feels from day to day. So what he's talking about is a lot of time, let's say for example, when someone is diagnosed with blood pressure, all right? So the surrogate marker here will be the level, like checking of the person's blood pressure level every day. Okay, you have to check the level, okay, if it's coming down or if it's going up. So they are surrogate markers. They tell us, okay, the extent or how the disease is improving or if it's actually um healing. All right. So, but one of the effects of this is that, or one of the disadvantages that is it do not directly impact on how a patient feels from day to day. Is the patient feeling well? Okay, if the blood pressure is coming low, but the person is not really feeling chemoacid, so this surrogate marker doesn't tell how a patient feels from day to day. All right. So we have another way of um another medical outcomes, we have the stage or extent of disease. So others measure actual stage or extent of disease, example, the stage of diabetic ulcer or the geographic extent of disease. This may have a more direct bearing of a patient quality of life or extent of suffering, but do not provide direct measure of long-term quality of life. So what is talking about? Let's talk as for example, the stage of maybe cancer. You have stage 1, stage 2, and then maybe the more the more toxic stage, all right? So this is talking of, okay, if we're talking of different stages of cancer, you know that someone that is at early stages of cancer, maybe person is really a kind of okay. So this may have a stage of disease, they have may have a direct bearing on a patient's quality of life or extent of suffering. You cannot compare someone at the first stage with someone at the first stage of cancer, all right? So, but still, they do not provide direct measures of long-term quality of life. So, the last but not the least category of medical outcome is patient-oriented and is the most important outcomes for guiding medical decisions. Okay, so it explains how patient feels and the quality of their lives. Okay, that's patient-oriented outcomes. Number one is maybe it's kind of morbidity, talking of suffering or the longevity, another consideration that bear directly on how a patient experiences his or her life. So in short, patient-oriented outcomes have primarily to do with long-term morbidity or mortality. So this talking of how a person feels, talking of the day-to-day um feeling of a patient, okay? Is a person feeling good? Is a person feeling maybe depressed about sometimes a sickness doesn't even kill person, but how the person react to the sickness or the quality of life the person is living actually kills the person. Do you understand where I'm going to? So patient-oriented outcomes is very, very important for guiding medical decisions. Okay, and that's why it's one of the key components of an evidence-based medicine, which is the patient values. Okay, so another simple workflow so this medical outcome can be classified into just two ways, which is disease-oriented and then patient-oriented. So disease-oriented, you just like combine the surrogate markers and then the stage of disease, which measure outcomes that are markers for disease, the silent numbers such as the blood sugar level, the blood pressure, the flow rate, and a lot, okay? So why the patient-oriented, just like what I've explained, is measures outcomes that the patients really care about. They have the potential to change the way we practice, such as reduce morbidity or reduce mortality, symptom improvement, improve quality of life, or lower costs. So I hope you've understood what the categories of measuring medical outcomes. So what are the benefits or advantages of evidence medicine? Why do we have to practice or why do we have to learn this evidence-based model? So the most important reason for practicing EBM is to improve quality of care through identification and promotion of practices that work and then elimination of those that are ineffective or harmful. Like, evidence, it deals with a lot of researches. It deals with you being current with the things, with the current um, researches and then the current works, okay, of clinical research. So it actually help in identifying a lot of practices that work. These are researches that are being valid or useful, okay? So it helps to know the ones that work and those that are harmful or ineffective. So EBM also offers the surest and most objective way to determine, maintain consistently high quality and safety standards in medical practice. It also can help to speed up the process of transferring clinical research findings into practice because the moment um, you use a lot of, because most of this research are what we use in making clinical decisions, okay? So it also has the potential to reduce healthcare costs significantly, okay? Because when you transfer, when these clinical researches are being used to make decisions in the healthcare, it can actually reduce a lot of healthcare costs, like trying to um, like develop a lot of new drugs that actually help to treat diseases. Okay, why there are a lot of clinical, if there already a clinical research on that particular disease. Okay, they also have patient satisfaction, which is actually a key component of the evidence-based medicine. So let's talk on limitations of evidence-based medicine. Number one is popular limitations, which include, okay, we have popular limitations. So EBM produces quantitative research, especially from randomized control trials. So certain population segments have been historically under-researched, like the sexual minorities and then people with comorbid diseases. Thus, the random control trials restrict generalizing because number one, the random control trials, they are expensive. Okay, so the priority assigned to research topic is inevitably influenced by the sponsor's interest. So this just talking of marginalization, maybe some population, they may there will be a thorough research on that particular population or that particular target group based on the sponsors. For this research, they make use of money to do this research. So when a sponsor or someone that wants you to do this research, the person actually wants you to do on his or her own area of interest, all right? And then the um major key quantitative research that this EBM uses is the randomized control trials. Okay, these randomized control trials, they are very, very expensive to carry out. So another limitation is the values. So while patient values are considered in the original definition of evidence-based model, the importance of values is not commonly emphasized in EBM training, which is a potential problem under current study. So in training for evidence-based medicine, the patient values are really under discussed. So there needs to be more awareness on it. Okay, we also have other professionals, most of those who practice long before the implementation of evidence-based medicine feel it undermines their clinical expertise and the value of their experience to a degree. So, cost. The decision related to which research program to fund raise ethical as well as economic issues. But it's obviously not possible to fund research in every known illness. So this is talking of most times the cost to fund a particular research can be very, very expensive, and which can lead to maybe some part of disease are being researched very well, while some disease are really under research due to the lack of funds. Okay, we also have lack of evidence. Um, uh, Critics of the evidence-based medicine have stated that the most commonly lack of funding for research means that there is lack of sufficient evidence for treatments associated with different diseases. Okay, different illnesses, especially those that are uncommon. Okay, so this will lead to lack of evidence on that on those diseases that are uncommon. Okay, because there's lack of research on them. So we also have the personal touch, also have lack of skills. Okay, some healthcare professionals have not really been acquainted with this EBM model, so they need to have so they cannot apply it because they don't have the skills. Okay, so these are all limitations of EBM. So we've talked on drug history, the evidence medicine, how to take drug history, what evidence medicine is all about, the benefits or the advantages, and they also have the limitations, and then the key 5 steps of based medicine. So at this point, I'm going to leave you with this self-assessment exercise, which is explain the anatomy of a good clinical question, especially using the circuit a tall component, okay, which is the pico or the PO. Also discuss the advantages or limitations of evidence-based medicine, define evidence-based medicine, and also applying the 5 steps of EBM model. So what is PICO and discuss its role in patients' evidence. Okay. So these are just the assessment exercise. You can leave it in the comment section or just discuss it so you can check if you truly understood what we've been talking about. Okay. So at this point, I want to say a very big thank you for those that are paying attention and for those that read to the end of this our discussion class. Okay. So let me get to know your feedback. What do you really understand in what we discussed today? Please drop it in the comment section, and please don't forget to subscribe and also share this valuable content to those that need it, or to any group that you know that we actually need it, maybe for exam preparations or for key educational learning. So thank you so much, and I'll see you in the next class.